So I'm Dr. Soyode, and we'll be talking about myasthenia gravis in children. I think I probably erred on the side of overachieving, and you may see more slides than we'll really go into, but at least the information will be up there for you to kind of review. So the first few slides, we'll go over the basics, which I'm sure everyone is quite familiar with, what myasthenia gravis is, and it's an autoimmune disorder, autoimmune neuromuscular disorder that causes weakness in muscles. It's usually due to impaired transmission of nerve impulses getting to the muscle, so there's a problem with connection between the nerve and the muscle in the neuromuscular junction. So even though, most people don't have a family history of myasthenia gravis, 3 to 5% of our patients will have, a family history. Prevalence is estimated to be about 14 to 20 per 100,000 population, so about 36 to 60,000 cases in the United States. About 11 to 24% of all myasthenia gravis patients have disease onset in childhood or adolescence. In the pediatric population, there's slight female predominance, and then males predominate in older age groups. So just to talk a little bit about normal neuromuscular function, and please feel free to stop me, raise your hand if you have any questions about anything I don't really dwell on. So acetylcholine, we know, is the neurotransmitter that helps the nerve talk to the muscle end plate, so the muscles know when to contract. Usually you get a signal that goes down the nerves, gets to the nerve ending that releases acetylcholine, and then it signals the muscle to do what they're supposed to do. So usually you have the nerve, this is like a picture of the nerve here. This is the nerve signals come down here. Acetylcholine is usually stored in what we call vesicles. It gets released based on the signal received, and then it goes across to the muscle end plate here, and it's by binding to the muscle end plate that it causes contraction. So normal scenario, like we talked about, electrical signal, the nerve ending release a neurotransmitter. It travels from the nerve ending and binds to the acetylcholine receptors, and then muscle contracture occurs. Now, for people who have myasthenia gravis, the problem is that the binding to the nerve ending, to the muscle end plate is impaired because you have antibodies that are sitting there blocking the receptors. We know for the autoimmune, we know a lot about the autoimmune etiology of myasthenia gravis. There's still a few things that are still unknown. Most people have the anti-acetylcholine receptors. There are, and it's the same in children as well, there are some who have other antibodies in their system. Anti-MuSK is one of the next one after the anti-acetylcholine receptor antibody. There are a few others that have been found as well. And 5 to 8% of patients won't find an antibody. So this just goes into the different types of anti-MuSK, or the patterns we see with the anti-MuSK myasthenia gravis, which, there are 3 main types. One is pretty much the same as the anti-acetylcholine receptor disorder, and then some have what we call severe oculobulbar weakness, which is prominent in the neck, shoulder, and respiratory muscles. And then the other one is limb weakness. So what has the thymus got to do with myasthenia gravis? There's still a lot that is unknown. We know that up to 70% of people, especially in the adult population with myasthenia gravis, will have a tumor or abnormality in the thymus. We know the thymus is important for immune regulation. In adult literature, it shows that most people will do well, especially if they're not responding to your first-line treatment with getting the thymus out. In children, it's debatable what to do, and you hear different things depending on where you go, but we find that up to 50% of kids will have remission of their disorder spontaneously. So, deciding on when to do a thymectomy is still kind of uncertain unless they're not responding to our first-line treatment. So clinical features of myasthenia gravis in children, most of this everyone here is probably quite familiar with. The biggest thing is the weakness, the fatigable weakness. For most people, gets worse as the day goes on. It can involve the eyes, bulbar muscles, which is your mouth muscles that you use to chew, swallow, and it can be more generalized or involve the extremities as well. When it involves the eyes, you get what we call ptosis. I'm sure Dr. Gleason is going to give us a very good presentation about some of that. Ptosis with eyelid droop and difficulty with moving the eyes, which can lead to double vision. And for some people, especially in the pediatric population, the first symptoms they have is just difficulty chewing and swallowing, which can be a prominent symptom, but eventually they will evolve into having other symptoms as well if we don't do anything about it. And then obviously proximal limb weakness that's more prominent in the limbs, the parts of your limb closer to your body, so your shoulders, your hips. So this is just a picture showing two kids with ptosis. One is unilateral, which sometimes can be the first symptom a kid has is one eye that just gets weak, and then eventually both eyes will get involved. Sometimes it alternates. Over time, usually the course of the disease is progressive. Weakness is restricted to just the eye muscle in 10 to 40% of cases. And most other people have progressive weakness during the first 2 years. Like I said earlier, 25 to 50% of children will have remission of the disorder, which is, quite impressive. I'm going to skip this one. It's a busy slide. I don't expect you to read it from where you're sitting. So just a little bit about classification of myasthenia gravis, which the Myasthenia Gravis Foundation of America has a system, a scale in place, which I just wanted to touch on briefly, but I don't expect everyone to memorize or know every step of the criteria. So mainly for the autoimmune myasthenia gravis in children, we see what we call the neonatal myasthenia, transient myasthenia gravis, and the juvenile myasthenia gravis. So I will run through a few slides just to talk about these two. The neonatal transient myasthenia gravis happens in about 10 to 15% of babies born to mothers with autoimmune myasthenia gravis. We believe it's because the antibodies cross through the placenta to the baby. For most babies, when they're born, we see difficulty swallowing, difficulty feeding. They're quite hypotonic. They have low muscle tone, very weak cry, and sometimes respiratory problems as well, difficulty breathing, and they may need to be on a ventilator for a short amount of time. Fortunately, as your body, as the own immune system matures and the mom's antibodies clear out of their system, they actually regain their strength and go on to live normal lives. In a small percentage of patients, they may end up with a few signs of weakness that is not significant, but enough to kind of linger over time. There are times when kids are born with what we call atherogryposis multiplex, which means they have contractures of all their muscles. These are the kids that the antibodies cross over the placenta early enough that they're not moving a lot while they're in the womb, because your joints are loose based on muscle movement. So by the time they're born, they have actual contractures. And even though there's a slide later on, in some situations, that's the first sign. This is one of the ways you may actually make a diagnosis in the mother, because there are times when people don't have a diagnosis. They have the first, the second baby, and they both have atherogryposis, and hopefully someone thinks about Myasthenia gravis as a potential cause and tests the mom. No. So this only happens because the mother carries those antibodies and they keep crossing. As the placenta is how she gives nutrients to the baby, but then it also passes out the antibodies too. Yes? MG is not hereditary. In most situations, no. Some studies in the past have actually found that even though we haven't, and some of you may just be how smart, the fact that we're not smart enough to figure certain things out yet. Because some studies have shown that family members in some patients, even though they don't have MG, may have EMG signs or may have some antibodies. So how all of that plays together is still not fully clear. So for the babies who are born, really what we just need to do is get them through the first few weeks of life, supporting them, making sure they're breathing right, help them feed, and we know for them they're going to get better with time. So this is what I was talking about, the recurrent congenital atherogryposis, when you have a mom who is yet undiagnosed with myasthenia gravis, who has babies who have the contractures, severe weakness at birth. And that sometimes helps us make the diagnosis in the mother. Now, the second category of patients we see is the juvenile myasthenia gravis. And this really encompasses kids from about 1 year old up into the adolescent age, even though it's very rare for it to happen less than 1, and most kids usually are on the older side, but it can happen earlier than 10. Most kids who have myasthenia gravis less than 8 years of age will have more of the eye symptoms, weakness, drooping eyelids. Older kids may start with the generalized form of myasthenia gravis, all the muscles involved. For the kids who don't have, like a resolution of symptoms, they can evolve from the eye symptoms to a generalized pattern, which is similar in adults too. So some of the things we talked about earlier, ptosis is the most common symptom. It can start off with just one eye, but then eventually spread to both eyes to involve eye weakness on both sides. Just weakness of the mouth muscles, chewing, swallowing can be quite common in kids. And sometimes what you also see is just difficulty talking, what we call dysarthria, where they have a hard time making words. They have the content of words is there. They have the cognition and smartness to get the words out, but they just can't make it's not coming out clear. And then myasthenic crisis also happen in kids. This is when you have the respiratory muscle weakness, you have difficulty, pretty much breathing, and you have to support the patient. So, like in adults, most patients with myasthenia gravis have a higher tendency to have other autoimmune disorders. And those could include, stuff like rheumatoid arthritis, thyroid disease, diabetes. There is a small percentage of patients who have epilepsy, and then the thymus-related cancers as well, or tumors. The path to making the diagnosis is pretty much similar to what we do in adults. In general, the first, for most of us in the pediatric world, we try to start with the less invasive stuff. So we do the genetic testing first, the antibody testing. And because most times with patients with myasthenia gravis, based on their history, what they're telling us in our exam, we can pretty much deduce the diagnosis, but then we can confirm with the antibody test. For kids who have negative testing, then we can go ahead with other more invasive stuff like the EMG, repetitive nerve stimulation, and the edrophonium test. We still also get chest CT or MRI to rule out thymoma in kids. We check the thyroid. We'll consider brain MRI scans, especially if it's just the eye ocular type and we're still not sure, because we want to make sure we do a thorough job. We don't want to miss anything else that could look like myasthenia gravis, but may need us to act earlier than later. So this is more detail about the antibody testing, but we'll skip this. On to treatment. So again, like with adults in general, treatment is similar in kids, except for the fact that the thymectomy may not be recommended immediately, especially in the pediatric population. So we always want to start with the anti-cholinesterase agents. So pyridostigmine is usually our first line of treatment, and for some kids, if that's all it takes, at a small dose, then we just maintain them on that and see how things play out, because some of them may have remission. Other options include the immune suppressing agents like prednisone, the steroids, then the steroid-sparing agents, including azathioprine, cyclosporine, mycophenolate, rituximab, cyclophosphamide. So those are medications we can use long term, don't have as much of the side effects as the steroids have, but can hopefully decrease symptoms or treat symptoms. Plasmapheresis and IVIG is also used in kids, like in adults, and we talked about the thymectomy as an option. So this just goes into really most times how we approach it. We start with pyridostigmine. If they're not responding to that, then we consider steroids. We consider adding on a steroid-sparing agent. If they have crisis, then we look at plasmapheresis or IVIG. And then by the time we have to go beyond pyridostigmine, then we need to be thinking about thymectomy, even in kids who don't have a tumor or anything abnormal about their thymus. One of the things we always have to be cautious about, both in the adult and pediatric world, is drugs that can make symptoms worse in myasthenia gravis. A lot of them are drugs that as physicians we use quite often. Some things are, like supplements, magnesium, people who have high magnesium levels, not always, but that could potentially make things worse. low potassium levels can as well. Then obviously Botox, because that works by impairing the neuromuscular transmission. There's a whole long list, probably not exhaustive, there's probably more out there, but this is a list of very common medications that most people will come in contact with that we should be aware of. Antibiotics, some are anesthetic agents, anticonvulsants, medicines for the heart, cardiovascular drugs, rheumatologic drugs as well. So I'm going to briefly talk about another group of disorders called the congenital myasthenic syndromes. So these are not autoimmune. They are mostly genetic. They can happen in kids really at any age, starting from newborn infants upwards. They are a little different from the autoimmune disorders. So rather than just affecting how acetylcholine binds to the muscle end plate, with congenital myasthenic syndrome, you have a whole host of possibilities from pre-synaptic to post-synaptic. So some of them may affect how you release acetylcholine. Some affect how long it stays on the muscle end plate. Some affect how it binds. So there are different kinds, and it can be quite complicated to make a diagnosis in these patients. The difference is it's also not as progressive, so their symptoms are usually mostly stable with worsening here and there a few times. So these usually start early in life, but because there's no easy way to make a diagnosis, it takes a while for most people to actually reach a point where we know what's going on with them. So similar to the autoimmune disorder, they have fatigable weakness. They have weakness in the eyes, swallowing, chewing, mouth muscles, and then limb muscles as well. So the areas where you can have issues we describe them as presynaptic, synaptic, and postsynaptic. That just means before, if you remember the chart I showed about the nerve ending, before you get to the point where you actually activate the acetylcholine, how you release it, and then how it binds. So another chart, so this is a chart that shows some of the disorders that make up the congenital myasthenic syndrome and where they affect the nerve ending. So the presynaptic ones actually slow down, affect how the transmission of the nerve signal gets here to help the body release acetylcholine. The synaptic ones act right here where the nerve ending has to release acetylcholine. So those genes are defective, so as a result, the way the body will release acetylcholine is also defective and inadequate in most people. Then the postsynaptic ones actually affect the muscle. This is the muscle end of the spectrum, how it binds, or they affect the receptors themselves and how they respond to the acetylcholine that binds to them, even if it binds well. So that's about it. Any questions? It has magnesium, so it's just something to be aware of. So it's not one of those kind of hard, fast rules. It's just that, sometimes people start having symptom exacerbation, worsening of their symptoms, and they're not really sure why. And you troubleshoot everything around you, you don't know what's going on. So it's good to have an idea of all the other things that could play a role in how your nerves talk to your muscles. So if, for instance, if you're on something that contains magnesium, then, maybe I should stop this for a while and see if I'll get better. Oh, no, not if you're soaking your food in. No. It's usually something you're taking orally. Probably is. Some people may not have issues with it, but so many things go into an exacerbation, and you may be fine most times, but one day other factors come into play, and then all of a sudden you're really weak. So it's a smart idea. Yes. Usually, yeah. It's small amounts, obviously, because the more you use of it, the more. In surgery, they have to be cautious. Yeah. Sorry. You go ahead, and we'll get to everyone. I think I finished on time, I hope.
My wife had Myasthenic Gravis and Parkinson's disease.
Oh, wow.
Both autoimmune disease.
Mm-hmm.
My great-granddaughter now has got a similar autoimmune disease. I thought I saw something about hereditary on your chart that said there could be in the family another autoimmune disease. I wonder if there's any connection.
Yes, there is. So oftentimes there's, even if other family members don't have myasthenia gravis, there's a high likelihood they'll have other autoimmune disorders.
I can't hear it. I got my report.
You get that?
That is possible.
It is possible. So most times there will be other autoimmune disorders in the family.
Yes.
Even if they don't have myasthenia gravis, there'll be something else. A lot of times.
This is another autoimmune disease. I can't help it. Got to do with the skin. Treatment is the same as myasthenic gravis.
Yeah, almost. For some of them, yeah. Okay, very good. I think you should at least pay attention to how much you're taking, and that's the kind of thing that if you're noticing more symptoms, it's best to take it out of your, stop using it for a while, just to be sure it's not playing a role. Obviously, if your magnesium level is low, that's a different thing, because it's really about how high the levels are in your system. Go ahead.
Is it possible to take too much methadone? Can you repeat the question?
Is it possible to take too much methadone? Yes.
That's not had worked with my wife.
Unfortunately, there are times when it's not helpful in some people. We have to go to the next level of treatment. Do we see down regulation of the receptors? So he's asking if we see down regulation of the acetylcholine receptors in people who are on long-term treatment. So do the receptors kind of become less effective, or the quantity is less? I'm actually not sure. I don't think so, but I'm not sure about that. Because your body is, if you think about it this way, if you don't have myasthenia gravis, you're constantly producing acetylcholine, and the receptor is constantly functioning. It doesn't affect it in any way. The issue is because you now develop antibodies that decide to attack those receptors or block. So no, it shouldn't, theoretically.
If it was true, wouldn't it mean then you'd be taking more and more methadone?
Yes. No, when we have to increase the doses, because this disease is evolving, so it's progressing. So we have to actually go up on the dose and sometimes switch gears and try something else because it's not working anymore. And that's when the immunosuppressive therapy has to come into play.
In that case, then what is the reason why transferase inhibitors are no longer as effective as they once were?
Because the disease itself is progressive in most people. So it's going to get worse. You're going to have more antibody activity, which is why, especially in adults, we're finding that early thymectomy helps with immunosuppressive therapy combined together. So the earlier you do that, the more likely you can actually get someone into remission or help with symptoms. The longer you wait to attack the immune overactivity, the harder it may be to control some people's symptoms.
That almost increases stress, exercise, not enough rest, and your symptoms get worse. It looks like the medicine not working, but it's because of the exercise.
The other things, yes. So then all of this looks simple because we have to kind of make it simple to make sense, but there's so much more that goes into it that some we know, some we don't. And the more, we're learning more and more every day, fortunately.
Do you have to have a tumor on your thymus gland in order to have it removed for MGMI?
No,
No, we were kind of told we didn't have any tumors, so they wouldn't take it out.
no, you don't have to.
But see, he was older too, and at first when we went to Mayo Clinic like 11 or 12 years ago, first they were gonna take it out, but they said it takes like 10 years to know if that's really gonna help or not. And then we went back a year later and they said, well, we don't do that anymore, we don't believe that it makes a difference. But the neurologist said he doesn't have tumors, so they didn't want to go with it.
I'm not sure what else they were looking at and why they made that decision. Okay, thank you. Thank you.